Hello, everyone, friends, colleagues, community partners, and welcome to our conversation in honor of the Bebe Campbell Minority Mental Health Month, presented by the Boston Public Health Commission Center for Behavioral Health and Wellness, InnoPsych, and NAMI, Massachusetts. So let's dive right into our conversation. Dr. Jackman, Dr. Simon, I'm so excited to be sharing this space with you all today. As both of you know, I very much so admire and respect both of you. We'll kick it off with an introductions, name and title, and just all of us will share a little bit about how our personal experiences have shaped our desire to support minority mental health through our current roles. So we'll start with Dr. Jackman.
Hello, everyone. Thank you for this invitation to be part of this conversation. As you know, I love talking about mental health, so just give me a time and place. I am the founder of InnoPsych, which is an organization that's charged with disrupting racial inequities in mental health. And we also do quite a bit of emotional well-being programming for employees. So thank you for that question about our personal connection. And so, I talk a lot about kind of why I started InnoPsych, and part of it was looking for a therapist for myself and my husband when we were going through a difficult time in our relationship. And it was really hard to find a therapist. We were very clear we wanted someone of color to work with. And it literally took us over 6 months to do that. And not just the time, but the challenge of the search process was really challenging. And I just knowing who I am and kind of my experience, connecting people to therapy, and I'd never gone through that experience myself. So that was really an impetus for me to start InnoPsych. But if I were to go back to childhood, I had two uncles, both are now deceased, who had significant addiction concerns. And we didn't really talk about it at all in the family. And so they're uncles who were very close to me and meaningful. They taught me a lot, and actually in their own ways, in their own respective ways, shared part of their own journey and recovery and relapse with me. And so I think that was a big impetus for me, really thinking about my community and how I can give back.
So one, pleasure to be with esteemed colleagues. And so I'm Dr. Simon, Chief Behavioral Health Officer for the City of Boston. In terms of how did I get to this work? So I think much like Dr. Jackman, I can go back to kind of family. And yeah, oftentimes mental health, even when I was a preteen, listening to conversations of adults, if something was related to mental health, it wasn't certainly talked about like at length or in depth. And kind of pushed to the side. And then for those family members that did have conditions, either comorbid or independently, that were mental health related, there were some family members, my mom included, that like took care of her youngest brother, who had mental health conditions. And kind of like every Friday, I'd go with her to like go drop food off at France, make sure Franz got to his appointments. But I'm not sure there are other family members, let alone other just community individuals that were concerned for Franz, but my mom was, because that was her baby brother. So thinking about going into mental health, recognize one, it's not something that we talk about. So in terms of disparities, they're all worse for persons of Black and brown descent. And for myself, I like child and adolescent, in part because most of the conditions when I was in adult training, it's like, oh, okay, this started back in when you were a teen, you were in college. So that training there. And so that's where the idea, I think, for people that like mental health and then working with youth population is this idea of being able to kind of pivot people or change trajectory. And so I think there is a little bit more hope and optimism for those that work with younger populations. Not to say that you can't have hope and optimism in older populations, but being able to be with teens, even preteens, is 6 months is a huge time in like a 10-year-old's life. A year in school is a huge time, versus you get older, time seems to slow down. So what we're doing at BPC is trying to, like NAMI, trying to profile the fact that mental health is something we should be talking about, shouldn't be ashamed about it, and that there are actual resources that we're trying to ensure more people are getting.
Yeah, it's funny. We've shared space before, the three of us, but I'm just now realizing one of the threads that we have in common is working with adolescents, young adults, and children in our clinical practice, which is a really cool connection that I'm just now realizing. I think for me, Dr. Myisha Rodrigues, I'm the executive director for NAMI, Massachusetts. And when I think about my personal experiences and how it connects to my current role, I had a unique experience growing up because there are a number of kind of traditional and non-traditional providers in my family. My grandmother, she was an LICSW for decades. And so, I was a kid kind of walking around the halls of her department and had always kind of been in that environment. My mom, she's a healer through the arts and has integrated mental health in a number of ways. I have an uncle who does both traditional and non-traditional practice, now more so mind body work. So I kind of grew up in a family and community of helpers. And the more I got to understand what was at the core of who I wanted to be and what I wanted to do was to be a helper myself. Although I didn't have the language for it growing up, I think navigating the impact of intergenerational trauma and some of the ways that then showed up in my own life and needing to access, therapy for myself, those things combined kind of led me down this path. And so, when I think about NAMI and what we stand for and the work we do in terms of support and advocacy and education, centering folks, individuals with lived experience, for me, it really boils down to access, systems, designing for the margins, and centering those voices that folks who are at the higher end of these systems tend not to hear. And really positioning them to not speak for them, right, but to amplify them so that we can impact them in multiple spaces. So, with sharing those introductions and thinking about this next question, I invite us to now have some conversation around stigma. Let's talk about stigma, and curious for us to explore how we feel stigma has impacted access to behavioral health care and mental health care writ large for BIPOC and communities of color.
Yeah, I'll jump in here. So I grew up in Brooklyn, New York, and what's very interesting about this concept of stigma is for certain groups, like talking to somebody, be it an actual psychologist or a therapist or a psychiatrist, is normal. And growing up in Brooklyn, having friends who, for instance, were Jewish, it's just commonplace, whether you're on the East Side, if you're in a Jewish community, like, you got a therapist. Like, it is a part of, like, life, right? So much so, you had Frasier, the actual, like, syndicated show. He was a psychiatrist on the radio talking, but he's a white male talking about, things that his community struggled with. And in our community, there wasn't that commonality of, oh yeah, I'm going to talk to this person. It's Thursday, or it's Therapy Tuesday. Like that this was not a thing. So in terms of stigma, I think one of the challenges that we see presently now is the idea that you might recognize something is concerning, maybe for yourself or a loved one, yet because it deals in the realm of mental behavioral health, the idea of, like, well, who do I go to comes up, because, like, the fact that, like, the three of us are on the screen, someone should take a photo, because it's very hard to identify persons of color who are well trained and can actually help a person in some evidence form, whether that's traditional evidence or non-traditional evidence. So part of the stigma is rooted in actual malfeasance of the system that we've been a part of. But then some of it is, I think, people just really not feeling comfortable with who would they be engaging in the actual process of talking. So I think stigma is a huge topic that we can't talk enough about. But to give airspace, I will myself.
Yeah, I mean, I think you're so right. There is so much that we can talk about, and I'll give a little bit of the historical perspective that I never learned in grad school, but I've learned through my own ongoing education. And, you know, I started to investigate kind of why are there certain things that come up. So, for example, one of the things that as you made our connection to working in schools. And so similar to you, Dr. Simon, my goal was to work with children and adolescents because I thought there was more hope for change. But then I realized that you're gonna have to work with the families too. And so it's definitely evolved in my career. But one of the things I would often hear from families and even young people themselves, well, if I go see the therapist or psychologist, you're going to lock me up. You're going to put me in the hospital. That was their immediate assumption. I'm like, well, where did this come from? And it was just doing research around this topic, I realized that after the emancipation of enslavement, there was this practice of using asylums to put people of color in hospitals without their permission or consent, even if they didn't have a mental health condition. So it was this new form of subjugation and incarceration. And so when I learned that, I was like, oh, this makes sense why we have this because we have such an oral history. And so the context has been removed, but the message about therapists puts you in hospitals remain. And so hearing that context made me really understand that connection. And then the other piece was learning about a practice called drapetomania that was proliferated by one of the early psychiatrists who would diagnose people who ran away from plantations as having a mental health condition, because somehow to try to escape enslavement, you had to be, mentally insane. And so again, learning some of that history, and then part of the intervention, the cure, was to amputate the big toe because that impacts balance and running. And so connecting that back to the message, childhood songs of "Any, Mini, Miny, Mo," right? So, so all of these things are so interconnected and deeply rooted without some of the backdrop. And so when we think about stigma, we have to really kind of bring forth some of the historical reasons. I think we think more about the Tuskegee studies and mistrust around medical care, but that, that also puts more of the mental health part in context. And so we have a lot of messages. I think to your point, Dr. Simon, we don't see images of therapists. We see maybe Oprah, right? And Yana Van Zandt kind of do some of this work as kind of community healers, but we don't see people with traditional degrees kind of with visibility. So I think we're definitely changing that. We're seeing with Dr. Thema as the president of American Psychological Association, Dr. Jessica Henderson Dan was one of the first psychologists, but we're seeing psychology and mental health come in more to our popular culture, and having those two, that integration, I think people are becoming more open.
One of the things in terms of the historical context that I bring up to my clinical colleagues that see people in emergency rooms is like physical restraint, right? Like the use of restraint. So both physical, i.e. soft cuffs, or pharmacological or chemical restraint medication. And I actually paired several like recent papers with an image of like actual chattel enslavement. I'm like, whether you believe it or not, this image here of a strong Black male shadowed, and then here it is, I can show you 2023, we've looked at 600,000 ED visits, and there's an overrepresentation of who Black male, public insurance, and the use of both physical restraint, pharmacological restraint, even so much so that back in the 70s when our psychotropics were coming out, having advertisements, right, literally in journals like well, not JAMA, but in American Journal of Psychiatry, where the image was a caricature of someone that looked like me, but angry. Like, oh, how to calm him down, Haldol. Same medication we use today, still overrepresented in persons of color. So when I engage people and I hear their fear, which can be clouded into the stigma, I don't actually dissuade it. It's like it's wholly understandable why I myself, as a psychiatrist, have to worry like, oh, all right, your son's not doing well. Okay, well, before you call, let me call, right? Like because I know what the chances are when someone, looks like us and has to engage our system, which classically does not have a lot of individuals of a lot of different teams who are culturally informed and understand that, this reaction might be a trauma response. And so, yes, gathering more people around them is actually counterintuitive to what you need to be doing. When I hear about stigma in some of our communities, it's really I just let the person have the space to describe it, because like I can't even tell you that what you're saying is inaccurate. It's like, no, actually I have a lot of evidence that is very accurate. So it is really challenging to bend it or lower it, and that's why we need more people like us having these type of conversations, because the actual lived experience of many people in the historical context is people do not get good mental health care, like kind of just cold blanket, I can say that. And you add layer of Jamaican, Haitian, cultural language. All of those are more reasons why, unfortunately, in our DSM, right, everything's in the context of the community that the person's in. Mm-hmm. Well, if the context of the community that the person's in, I'm thinking about it from my vantage point. Oh, your paranoia, which actually might be very rooted in truth. Like I get a little palpitations, even though I have friends who are cops, I get palpitations a little bit when I hear the siren, right? If I told someone that in the wrong context, they might be like, oh, look, this guy, he's paranoid about cops stopping. It's like, oh, yeah, shit, I am. Right? I understand that. So I don't push that towards the psychosis. I say, oh, no, this is wholly understandable. And I mean, I mean, just give it. I just said, no, this is appropriate stress that you are feeling.
Yeah. And I'm glad. Thank you for sharing that. And it's true, right? And I think you're highlighting that if a clinician is then savvy, hasn't done the work of understanding different cultures, it can be very easily to pathologize someone's normal response to systemic racism. But I wanted to highlight one other that you kind of hinted at, but you didn't, was around the Haldol and the use of the increased diagnosis of Black men with schizophrenia and thought disorders that coincided with the civil rights. And you talk about angry, right? And so prior to that, prior to the 70s, you saw schizophrenia and thought disorders, psychosis being diagnosed more in white women. And around this time of the civil rights, where people were angry, we started to see, as you would say, the chemical restraint of Black men in particular, and the overdiagnosis or increased diagnosis in mental health conditions like psychosis and schizophrenia. So just wanted to add that tie-in. It's like, it's all connected, right? So
thank you for sharing those reflections. I think when I was thinking about my responses to this question, one of the first things that came up was stigma in the community, right? In our communities and communities of color. That has thoroughly been explored, so I'm not going to talk about that one. But I think that in addition to thinking about stigma and access, if one's personhood was devalued, misunderstood, different perspectives were projected upon large groups and communities of people, of course, we would venture to then say and see that systems of care also hold those same values, and were never structured to center care for those persons to begin with. And so, and that's, I would even say, not just systems of care, but systems writ large, right? So when we look at, I think Dr. Simon, your point in terms of access to therapy, not everybody can pay for therapy. Right. So how, access to fiscal resource, upward mobility across various communities of color, insurance, access to insurance, insurance restrictions. And then, something that I know that we've discussed before is just a lack of clinicians of color. And so, I would say the biggest compliments I've gotten during my time as a clinician, this was years ago, and I was, first starting out. It was a group of boys of color, seniors, and we were doing a transitions group. And so there were a number of topics that we covered over the course of the year, right? Relationships, grief, substance use, right? A number of things. So we're at the end of the year and we're having our final kind of transitions meeting. We all decided we're going to meet outside. It was nice out. We went to Subway, got some food, right? Had the whole thing set up. So we're getting close to the end of the meeting. And so I asked them, I said, so do you think you guys will get therapists in college? Do you think you'll continue with counseling? And beyond a shadow of doubt, all of them looked at me and, it was a school setting. So they call me Miss. So they're like, Miss, I'm not into therapy. Like, that's not me. Like, that's not what I do. And so I chuckled and I smiled and I looked at them and I said, so what do y'all think we've been doing for the past 12 months? And they were like, wait a minute. And we met at a set time weekly. There were topics that we covered, right? But for me, the reason why that's probably forever will be one of the greatest compliments that I've received is because for me at that moment, it was an indicator of the trust that was built, the comfortability and the safety that they felt they had to be vulnerable with me, the level of genuineness and authenticity that was allowed in the space, not just of them, but myself, right? And what I was able to bring to that space as their therapist. That can only come through culturally responsive treatment. And it's not to say that if someone is of another culture that there's no space for that, because I do think just being genuine and authentic in and of itself, right, like that does lean toward a lot. But when we think about stigma and access, there are some fiscal and capitalist aligned challenges, if you will. But this piece around BIPOC clinicians, I also think really can make a difference. And not just BIPOC, I think, there are other identities, but given the purpose of this conversation in this month, that's what we're centering.
Yeah. No, I think thinking about like the finances and it's a challenging conversation to have because irrespective of yes, they used to have carve-outs for behavioral health or mental health versus quote unquote physical health. In the time that we're in, where yes, there's a recognition of okay, people should be seeking out some type of mental health services. It's interesting, and perhaps because this is a human-centric endeavor where yes, altruism is thought of in the broad sense of like healthcare. In really no other field or realm that I can think of is something in short supply, not high cost, right? So if somebody who's watching wants to go to Tiffany's to get a diamond, it's like, well, the Tiffany's diamond, they're rare. There's an extensive cost. And so I think the challenge of trying to find a provider, it is just the economics of when something is rare, it often has a higher cost. And then if you want rare and in this context, like highly trained, well, the cost goes up. Oh, rare, highly trained, and yes, female, and has this particular training. And so it's an interesting dynamic to see when there are very few BIPOC providers, and then those that are some like I'm looking at that are really very well trained. I would not be surprised if the fee structure is such that it feels challenging for people to be able to seek that service out. And then also when we think about persons of color and giving actual like one-on-one, really culturally defined, individualized care, it's going to exceed the time commitment that the system wants you to kind of like operate in. And so there are times where when I see individuals, they're like, how long is your intake? I'm like, yeah, it's like 90 minutes. Like 90 minutes. I'm like, yes. In part because I'm going to talk to all of y'all. There's a lot of information to get. And the confines of like 45 minutes, I don't know who came up with it. I don't know why they came up with it. But there's certain things that are just more challenging to do. And if we're talking about certain populations where it takes time to feel comfortable, you can't do that in the quote unquote 15-minute follow-up. Like, it's just like, I don't know what's happening in 30 minutes. And I'm supposed to talk to you about a childhood issue. I got it. Like, we have to be friends, right? For me to just come sit and just, if I'm just meeting you, it's going to take a minute to be like, Myisha, okay. And culturally, how our culture, then I'm being just broad to say like non-US cultures, engage is almost antithetical to psychological training, where this idea of, maskless and I am to be somewhat unambiguous to the person to allow them to project onto me their relationships that they have challenges with. And so then I'm supposed to recognize the transference and counter-transference. But if you're not kind of psychologically minded going into that, and you feel like, oh man, this person's giving me the wrong vibe, right? Transference vibe, right? They're not coming back. It's very different when I, as a psychiatrist, went to therapy because like, well, I need to be doing this thing. People have been coming to me. First time that I engaged someone in Massachusetts, it was a true psychoanalyst. I sat down. He sat down. They didn't say a word. I was like, I'm looking at my clock. Maybe like a minute, 2 minutes go by, and a minute, 2 minutes, when there's just silence and it's just you and some person you don't know, it's like, what's going on here? I'm like, my name's Kevin. But I understood what was happening. It is very unlikely that he could have done that in other environments with other types of clientele. So, I just talking about the finances and the culture of what it is that we do when we're meeting with people. I disclose often because I'm trying to get you to feel comfortable with the idea that I'm a psychiatrist, but I look like you. And yes, I go to church. Yes, I have kids. Yes, I have artwork. Right? Like I gotta somehow let you know, like, it's okay to talk to me.
Yes. That's a perfect segue. I'm going to transition us to this next question. Let's discuss what impact we've seen racism have on our systems of care. I know we've talked about stigma from a both historic and present day perspective. So in exploring racism in systems of care, it can include present day and historic factors, but let's transition there. Dr. Jackman, I'm curious to hear your thoughts.
Yeah, I mean, I think I can definitely pick up from where Kevin was talking about in terms of like, what is the experience of therapy? What is the experience of therapists? And people walking into those systems have no idea what to expect, because therapy by design is this private process. It's a closed door. We kind of we get snippets from movies and TV shows, which does not do therapy justice by any means. So people come into the process with really not a lot of understanding about what it is. I think what happens once they get there, and I can talk about, you know, my work as a clinician in a high school, I think, you know, the design of mental health, you know, really needs to be kind of overhauled. So, you know, one of my modes is always to educate people about whatever process we're going to go through. And so once I had a young person who would need, for example, to go to the hospital for an evaluation, this is someone who was most likely suicidal with no safety plan, meaning that they could not kind of articulate ways that they could keep themselves safe. Those are kind of the stakes or the bar at which I would have a teen be evaluated. But the process of going to an emergency room, as you might remember or know, is you might get transported by ambulance. So there's already a cost there. Sometimes families would not want to incur that cost of the hospital ride to the emergency room. And sometimes we would try to help families make that decision, either take the child, but there's a risk involved in that. Once you got to the hospital, then you needed to be cleared medically first before you could even see a mental health professional. And think about what's happening in the emergency room. There are lots of things coming in. There's not usually, unless it's a child-specific hospital, but usually you're in there with everybody else. And so it would often mean being in an emergency room for long hours. By the time the child saw the mental health professional, they're either have re-regulated, they're so mad, right? They don't want to do anything else with this process and may actually, you know, feign that they're better, right? So I think think about that emergency service, like when people are having severe mental health conditions, what happens in that process is really drawn out. And I get why for some reason, but I think we need to really figure out how to streamline that process and have the person see a mental professional much earlier. But I think that whole system really leaves a bad taste in people's mouth. Like, I don't ever want to go back there. I think what other systems of care we think about, and you both have hinted at some of them, right? You know, seeing an outpatient therapist, right? You have to go through an intake process. It feels very depersonalized. As you kind of hinted, Dr. Simon, right? You're telling all your business in the first session, right? Recognizing that people are really hesitant to come into this process, but that's kind of how you have to get your background information. There's not a lot of knowledge about that. So we try to do that at InnoPsych, just to educate people about the process. So you do your intake. I think a lot of models are you go to the clinic, right? There are some definitely home-based resources where I think it's helpful, but not all insurance cover home-based care, right? Where the clinician comes into the home unless it's kind of an emergency or a high need situation. So again, thinking about how we prioritize, I guess not how we prioritize certain cultures, right? So thinking about access, like, do you have transportation to drive into a hospital? A lot of our hospitals are downtown. It's expensive to park, right? There are all these barriers. Maybe it's T accessible, maybe not, depending, right? And so all these barriers that a family or a young person has to go through in order to get care. So yeah, I mean, I'll stop there. I know Dr. Simon will probably have some to add to that, but yeah, those are, I think, some of just the barriers. Get into the place. So when you get there, what happens?
I wholly agree here. And in terms of thinking about how does kind of racism seep into our systems, you've mentioned school, so I'll mention like in the actual like facility. This has happened time and time again, unfortunately, where I'm the covering doc. I have to go to like an actual inpatient unit to, see kids. And there's the 14-year-old girl, African-American. And, it is suggested to me that, she's one to watch out for. I'm like, we're in an inpatient unit. They're all to watch out for, right? It's like, why are you singling out one versus the other? We're literally on a unit where, by virtue of being here, people have been dysregulated or something is serious, right? So you don't have to alert me to this particular patient. Yet that often happens when their Black female patients, because oftentimes the actual like milieu staff, those who are like on the unit, the 24/7 or several shifts, don't look like BIPOC patients. And so they do bring in their own biases, whether they recognize it or not. And so something that I recognize and I appreciate when I'm able to engage a BIPOC patient is being able to do some little mini processing that I suspect sometimes may not occur given the dynamic of units. So there was a girl who, 16-year-old, having tension with her mom. She's on the unit, and I'm trying to get a little bit of information about what's going on. My mom doesn't want me to, in essence, be the 16-year-old, like go out, not come in on time. I'm like, well, your mom wants you to be safe. And then I'm like, how old is your mom? So the kid's 16. The mom is 36. I said, oh, that's interesting. She said, well, she had me at 19. I was like, well, you're telling me this, but yeah, So I'm wondering, actually, let's just look at your mom's perspective. She's seeing you maybe like she saw herself. So I'm just very curious. What's your mom's relationship with your grandma? She said, oh man, they're hot and cold, but she goes for her for everything. I was like, oh, that sounds potentially similar to like what might be happening here. And being able to do that little bit of processing, the next day when I came around, she said, oh, I like that conversation we had. Mm-hmm. Right. But that's me taking the time to say, wait a minute. Psychologically, what's happening? Mom's literally seeing herself and trying to shift potentially her parental style that she received, which you are not, in sync with. But I saw her for her. I didn't see her as the hothead girl. I saw her as just a 16-year-old, teen that I could relate to because I'm seeing her. So I always tell trainees, like, you literally have to see the patient. Like, you can't envision what you're seeing, like see them for the person that they actually are, listen to what they're saying. They're often giving you clues as to what the challenges are. And it's very important for us to be able to recognize it. But in terms of racism, right, like it's so pervasive that, again, chattel slavery, drapetomania, the idea of being stronger, those things seep into even well-trained clinicians and nursing staff. And it's almost as though all that goes out the window. And what's stagnant with them is the tropes of what it means to try to engage a Black man. So racism is unfortunately very, very, very pervasive. And I've seen it hospital systems, state systems, schools. Plenty of times I've actually engaged families from a school system perspective, kids dysregulated all the time. They see me, but now I engage the school. So I and the systems that I'm a part of engage the school. All of a sudden, the kid's behavior changes. I'm like, I actually haven't even prescribed him a medication. It's your perception of, oh, this family's actually engaged. Oh, they actually have a provider. All of a sudden, you are responding as a system very differently to when he with autism is dysregulated. But you're now responding the way you should have been the entire time. It's not actually that I've done something different. And I've seen that too often.
Yeah.
To your point, to be clear, how those perceptions shape actions and behaviors that often determine how we then engage those students, what we or folks with lived experience, because it can be in any environment, right? What treatments we think they need, boundaries that we feel need to be set, prescribed, whether it's communicated or not, outcomes that we anticipate this person having as opposed to someone else that we might perceive differently, right? Something that you guys were bringing up in terms of some of the aspects of the system, I just want to identify and kind of tease out a little bit, right? So when we think about, emergency room care is named, private practice was named, folks that are kind of ensuring these systems run, right? At some point, we've had some level of training. We have agreed to abide by ethical codes. There are, as you've named, structure to sessions, what types of information and content we cover in specific sessions, the timing of our sessions, right? And ways of providing treatment.
And can I add one more?
Yeah.
The staffing, right? And who is on staff, who's hired.
That too.
Right. And who's not hired because they're not pursuing these jobs because we're told mental health is not a thing. Our wellness is not something that's prioritized. Mm-hmm. And so young people aren't attracted to this field.
Right. So when we're thinking about this, none of these facets of our industry, our field, have been grounded in, writ large anyway, right? At least in this country, grounded in African, Asian, indigenous, Latinx cultural traditions, right? It's those of us who are taking it upon ourselves to integrate some of that while, doing our best to align with the systems and structures that we were given, and that we, figure out how to operate in so that we can continue to remain licensed and be part of the very small percentage of folks that can provide care and support for BIPOC communities. There are, in terms of organizations, folks like InnoPsych, Pure Spark, Dee Dee's Cry, Kiva Centers. When I think about more like non-traditional entities or organizations, there's GEMS in New York that takes a completely non-traditional approach to working with adolescents and primarily girls who experience commercial and sexual exploitation. Here at home, there's Think Kids, who engages a completely non-traditional approach that pushes against kind of conventional ways of understanding and identifying behavior and skills development, right? So, I think that if we are to kind of push against some of the ways that racism has shaped our systems, we need to move past being culturally responsive. And we need to be able to adapt to culturally embodied ways of being and doing the work, and being willing to kind of look outside the box, because the box as it's currently structured, it's not working for everybody.
No, I wholly agree here, Myisha. One of the things that I recognize and have written about is the fact that I have a lot of clinical training that I had to learn in reference to being boarded and licensure. Yet I had to also learn it to know what not to do. Because there are times where, and I tell people this all the time, I'm like, the practices and the evidence that we have actually can work. Unfortunately, they're not done in efficacious ways. And with groups, it's not been demonstrated. But I'm like, when I'm talking with a youth, right? You had some X number of youth, 12-month period of time, meeting regularly. They undoubtedly got better. That's an evidence-based treatment, right? Like, but how we frame things. So I tell parents, I'm like, you don't have to tell Kyle, Johnny, Susie, who I am, what I do. You let them know it's Kevin. Whatever they want to call me, they can call me, because I recognize I have to accommodate to the child and where they are. Child psychiatry. What does that even mean to an 11-year-old, right? But I think we, in our field, we come in so prescriptive and have this air of, oh, if you listen to me, It's like, well, no, you should be listening to them. If you listen to me, oh, it will get better. It's like, well, no, that's not necessarily true. And the way in which we are taught, I understand there's a process, but oftentimes it's like you have to learn it to then be able to shape it for yourself. So like intakes, I never really start with, well, why are you here? Because a lot of times, like, I don't know, my mom told me to come. It's like, yeah, that's not really gonna be helpful. I'm like, okay, hey, let's start with things that you know. What grade are you in? Right? So you just start to just get the person on a flow. And then there will be a pivot where I start to say, oh, well, that's interesting. Your grades used to be this, but now they're this. Like, what happened? But if I just started there, why are you trying to ask me about school? Right? So I think that's the challenging component of trying to introduce these ideas and careers to people, particularly that are BIPOC, is one, we can't be everywhere. And unfortunately, those who can't communicate well, like you two, you can't be at every school. And so it is unfortunate. And I'm sure you get the emails, people very interested with wanting to like be a part of what you're doing. And you're like, yeah, but I'm doing it. So I can't really slow down. But we have to be able to communicate that to students and say, yeah, you can do this, what I'm doing, in your way, in your flavor. Where when I talk with guys, I'm like, do you listen to music? They tell me, I'm like, okay, how about you listen to track 3 of Kendrick Lamar? Right, like I will get to that level because I know if I just say, oh, go to journal, it may or may not happen. But if I say, oh, listen to this thing, and next time we come back, if they didn't, I'll like intentionally have it. Say, hey, let's just listen to this. Well, what do you hear? But that was never taught to me to
Right.
Pull up Kendrick Lamar. Like, no, that's not in the textbook anymore.
It's culturally embodied. It is a part, you bring that because of who you are, how you were raised, how you developed over time, cultural norms and values, right? It's a large part of who we are.
Yeah, and I see that you're really speaking to the idea of, I think in our training as mental professionals, there's so much constriction and removal of the person. And that is a model that doesn't work when you come into communities of color. And so I think, one of the things that I do when I'm training mental professionals is I'm like, you can't leave your lived experience outside the door. That has to come in with you. You're bringing all of that because that just adds to your creativity, your authenticity, right? Kids are going to want to come see you and continue to see you if you are showing up as your true selves. Of course, there's still going to be some boundaries about what you share, how much you share, but you definitely have permission to share who you are because otherwise they're not going to get to know you. Right. So a couple that I wanted to highlight, Mental Health Access Project, which is really about educating young people about mental health careers and giving them career exposure. I think that's a great opportunity, a great program that is really focused on building a pipeline of young people of color into the field. The Triggered Project, they actually, Keith Maskell and his wife, Roxanne Maskell, I think they blend the traditional and non-traditional. She's a social worker. He's an artist and actor, has used his personal experience with sexual trauma to develop a program that's really powerful in helping men to talk about their own sexual trauma history, right? So as we have, how do we help continue to lift up people in community who have experience and want to share it, right? We often can hear the wheels go like, oh, are they licensed? Do they have this, right? And so how do we partner with people with lived experience so we can elevate our expertise and bring that into the community? There's one that I wanted to, and I'll end here, that's not in the Boston area. It's in Zimbabwe. It's called the Friendship Bench. And they train grandmothers, right? Like how important of that to maintain generativity and keep, the respect for elders in our community and give them a sense of purpose. So they train them how to have sessions, using cognitive behavior therapy with people. And so there's a particular bench that's identified, and people in the community can come in and have a conversation with the go-go, is the grandmother, right? So how do we kind of find ways for people who are our community brokers, who have that social capital in community, whether it's our pastors, right, or elders, how do we continue to help them be partners with us in this work? Given we have a youth mental health crisis, we have a loneliness crisis, like how do we kind of leverage our communities to help elevate, and because we all need to be part of the solution, right? And one-on-one therapy is not for everybody, and it's not going to solve, right? So we need to think about more group-based and community-based interventions.
Yes. Both of you all, I think, brought up a really interesting point there, because I think Core Mental Health are also working with some entities and training for more of that work to happen in barbershops and salons.
Mm-hmm. Right.
So I would agree. I think that, to Dr. Simon's point, there is purpose to aspects of the training, right? Like it has been shown to work. And right, like there needs to be a both and. So I love the point that you bring up, Dr. Jackman, in terms of, so how can we leverage those skills, acknowledge that they are just that, skills, and there's a lot more perspective, lived experience, cultural perspective and value that other folks can bring to the table. How do we merge that together? Because as we've named, like one person, 2 people, 3 people, we need a lot more. So as we transition to the last question, which will be our closeout question, and we'll wrap up here, because I think we're starting to transition there anyway. What are some ways that we've seen communities show resilience over time?
Yeah, so I think in speaking to Western culture in the States, so Dr. Jackman just mentioned church, right? So historically, for BIPOC communities, for as long as we've been here, being able to gather in communion with each other in fellowship has been a therapeutic space. And it's one that even to this day continues to be therapeutic for many people, in that, it's the place that you can go and at the end of the service, go to the altar and bare yourself, right? So certainly church is very valuable. And group therapy is something that I think people are far more comfortable with, particularly when we're thinking about ethnic cultures, in that it is just more in alignment with culture to be communal with people rather than this one-on-one idea. So I think that there are ways in which our communities have demonstrated an ability to, because otherwise no one else is helping them, figure it out for themselves. I just was in Buffalo 2 weeks ago, and literally after March of last year, where there was a horrific tragedy, the community said, we need to identify Black-owned emergency mental health response, because the type of response that we're otherwise getting is not helpful. And so that's community saying, we're in tragedy in the moment, and we need to figure it out in the moment how to help, because it's going to be long lasting. So there are definitely ways in which communities have demonstrated some resiliency. And I just wanted to highlight the friendship bench, like in New York. So they had Thrive NY, and they had a version of the friendship bench, big orange benches.
We'll come back to Dr. Simon when he comes back. I think one of the things that's really about, how do we message mental health to folks? And, I think our communities are used to coming together in times of tragedy and protests. And I really want us to see us come together for times of healing and thriving. I think about the quote from Bell Hooks. She talks about, we've been taught that wellness is a white luxury. And I think really about, let's upturn that, right? Let's kind of elevate that and think about we as individuals, as communities, really, it's our time for healing. And I think for too long, you know, we've dismissed therapy because we were told that it was not for us. And I think we bought into those messages. And I think I'm definitely seeing change, that people are seeing like, yeah, this is for me. I'm seeing people who look like me lead this work. And I think we have to, we're trying to disrupt like who has knowledge and whose knowledge is valid and not valid. And I think this discussion is really highlighting that there's a lot of community wisdom. There's a lot of healing in our own communities, right? That or healing strategies in our own communities that we've kind of dismissed or not really elevated. And I think this is our time to just tap into that and recognize that we, you know, we are who we've been waiting for. And we have tools, and we need to leverage our tools to do that and to benefit our communities.
I couldn't agree more. I think another area that I'll add to that is the arts. You know, culturally, I think the arts has been a part of who we are as BIPOC folks of color, the global majority, you know, whatever you want to call the collective group. I know in my own personal life, it's been healing and allowed me to kind of find, you know, voice when speaking wasn't really best fit. You know, as an artist and as a former dancer, I've seen it show up in a number of folks' lives. And I think, you know, to that end, arts and entertainment writ large and what we're seeing with pop culture, there's a huge shift. You know, I think earlier we had mentioned, you know, seeing clinicians in the Black community, right, and having access to that type of mental health and behavioral health care. There's lots of, you know, new television shows that are showing up on streaming platforms with, you know, Black dominant casts. And there are therapists that are kind of woven into the plot. And so you're seeing Black women and men owning these roles, and you're seeing the characters go to them, and that genuineness and that authenticity that I was mentioning earlier, showing up in partnership with, you know, some of these tools and skills that we're identifying that we've learned over time, right? So, you know, I definitely think that the arts has a way of not only healing in and of themselves, but also challenging stigma, helping to recreate the narrative, getting information out there. I once had a student who that I was working with some years back, and she was experiencing suicidal thoughts. And when we came back together the following week, because she had had an experience over the weekend, I said, well, you know, so what did you do? Like, what prevented you from acting on it? And she said, well, I heard that song and I called the number. And I was like, what song? And she's like, you know, that 1-800-NUMBER song. And I was like, oh my God, it's working. Right? Like she, you know, she was able to access it, take a risk, try it out. So yeah, and I think the last thing that I'll say before I shift to, and hopefully Dr. Simon joins us again before we complete.
Can I add into that before you shift? Because I think that in our conversation, we haven't said it explicitly, but I think we've implied therapy as talk therapy. And I think what you're highlighting as well is like there's so many aspects of therapy, and I want to bring in the expressive arts therapy and dance and movement, you know, writing, journaling, using poetry, music therapy, hip hop therapy, that there's so many other models and modes of getting support that it doesn't just have to be that, you know, that kind of traditional model that we kind of keep in mind.
Bodied work, and a number of those, I think for me, as we talk about how we've adapted for ourselves as clinicians of color, that's what that's looked like for me. You know, it's pulling in the arts into my practice and pulling, you know, approaches that are grounded in the body and helping people to tap in different ways. You know, I think one of the things that when I think about all of this, you know, there are specifics that we can highlight and sometimes can get kind of sensationalized. But I think, just simply put, like cultural and community values and ways of being, that get passed on. Like earlier, we were sharing about some of the historical traumas, right? And intergenerational trauma and ways that, one, it gets passed down, but two, it's continued, right? Through systems and those in power, et cetera. But we've also had beautiful, restorative, healing, creative, community, and cultural ways of being and values that have enabled that resilience, right? That have enabled and kind of counteracted, some of the traumas that have been passed on. And some of it's not an approach or some of it's just how your parents and your grandparents raised you, how the conversations you had with your auntie when you were little. Seeing your church family, as Dr. Simon identified earlier, and other, religions that show up in many different cultures, whether it be Santeria or, Buddhism or, indigenous practices for, First Nations groups. So I think there's a lot of beauty there, despite the pain that we tap into.
Yeah. I think about even community, we think about, I think in this conversations, we've been talking about just non-traditional healers and helpers. I think about the Black Joy project that was started by Cleaver Cruz in response to just seeing all these negative messages. And he's like, I want to see Black Joy. Yes. Janae Osterheld started a similar project, A Beautiful Resistance here locally, right? Just showcasing the humanity and the beauty of Black people in our livelihood, right? Just elevating those messages and reminding us, but other people, like we're people, we're human too. And I really appreciate some of those because I use those in my practice. I think those are ways that I bring in kind of the pop, again, because our clients are living in society. They're not living in our office. And so it has to be able to be translated between the two spaces.
Yes, yes. We welcome back. We continued while you were out, but your timing is perfect. We just kind of gave our closing reflections. Do you have any closing reflections before I close us out?
Yes, no. Thank you for not ending without me. The devil is always around. So yeah, in terms of closing remarks, I think one, just appreciate the opportunity and space to have this kind of conversation. I think it definitely is needed and certainly want to have more of it. And for those who are in the Boston area, certainly try to seek out services, whether that's through the Boston Public Health Commission or through NAMI. In terms of family support services, there are activities, there are services that are available, even in the time that we're in. And we certainly want to be helpful. So just appreciate the opportunity to share space with you too.
Awesome. Well, thank you both, for sharing your time with me today and gathering to, as we've said, discuss an important topic. Clearly, the work is far from over. As we know, racial inequities in our systems run deep. But we do hope that this conversation, as others watch it and we post it in various places, we hope that this conversation will help spark a more critical look at how we can change some of these systems and practices, because it will take all of us and more than us here, right? It's going to take a collective commitment to social justice and liberation for greater mental health, for communities of color. A special thank you to those who are watching, if you're watching this now and joining our conversation. If you would like more information on our organizations or resources on the conversation itself, that will be provided in a closing slide, and you will see that next. So thank you so much.